We also request that you fill out a survey telling us what you thought about the webinar and what subjects you'd like to see in the future for webinars. And that survey can be attained down at the web links module at the bottom right side. But because we get such low participation, Sarah's going to actually put the survey on your screen at the end of the presentation, and we'd like to have you just take a minute to go through that and tell us what you thought about today's presentation. You can also find links for our website for our upcoming conference and for to sign up for our newsletter. We have a bi-monthly newsletter that talks about telemedicine in the region, and we encourage you to sign up and see what we have to say. Today's presenter is Dr. Jeffrey Saffle. Dr. Saffle is a native of Utah and attended college and medical school at the University of Chicago, where he graduated in 1976. After graduation, he returned to Utah and completed residency training in surgery, as well as doing a fellowship in burn care at the University of Utah. He joined the faculty there in 1982 and served as director of the Burn Trauma ICU from 1985 to 2012. He's board certified in general surgery and surgical critical care. Dr. Saffle is past president of the American Burn Association and the Southwest Surgical Congress, and he's served as chairman of the American Burn Association's Multi-Center Trials Group. He also serves on the Medical Advisory Board and Research Advisory Board of the Shriners Hospital of North America. Dr. Saffle has published over 140 articles in peer-reviewed journals and a number of book chapters and numerous abstracts. He currently serves as director of telemedicine for the University of Utah Health Center. Dr. Saffle, I thank you for presenting today, and take it away.
Well, thank you. I hope you can hear me adequately, and if I'm too loud or too soft, please let me know. I'm very glad to have an opportunity to present. My first experience with these webinars was a couple of months ago when I watched an excellent presentation that Dr. Kamali gave on the Tele-ICU program in Anchorage. I was very impressed both with the program and with the presentation that he gave, and I'm glad to have a chance to share some information with you guys today about our burn program. In starting off, I do have some objectives which I was asked to provide. I would like to spend a little bit of time kind of emphasizing the reasons why access to burn care is such a problem, particularly in our part of the country, because of the declining incidence of burn injuries, which has led to a decreasing number of burn centers, and a general lack of physician training and awareness about burns. We have found telemedicine to be tremendously valuable in extending burn care expertise throughout our region, in both acute situations and in patient follow-up. And in doing so, I would like to be sure nobody forgets the relatively simple use of store and forward technology, which has also been very helpful to us. As kind of a bonus objective, I guess, I would hope that you would think about how these principles could be used to extend expertise in other specialty fields as well. I have a couple of assumptions in moving forward. First, I assume everybody that's tuning in today knows a fairly good deal about telemedicine. I expect that you probably don't know a great deal about burn care, so we will spend some time talking about that. And since you are healthcare professionals, and since everybody expects burn doctors to show a few gruesome photos, I have a few. So I'll try to warn you when those are coming up in case those bother you. I'm getting a couple of chat about my voice either echoing or being difficult to hear. Bob or anybody, is that a problem right now?
Most of us can hear you pretty well, Dr. Saffle. And I thought the echoing was probably from my end of things, although I'm using a headset. So just continue and we'll see if we can work it out.
Okay, no problem. We always begin a presentation like this with a picture of our institution. This is the University of Utah Hospital. The burn center is on the 4th floor of the main hospital. But like a lot of medical centers in recent years, we've branched out so that we now have an orthopedics hospital and an ophthalmology hospital and a neurosurgery hospital and a cancer hospital, so that often most of what is treated at the main university hospital is trauma and critical care, and the burn unit really falls under that banner. We also always want to remember the wonderful team of people with whom we work. This is a picture of the burn team at the University of Utah. Burn teams are, in my mind at least, particularly cohesive. We work very, very closely with the nurses, and in this photo there are physical therapists and social workers and nutritionists and pharmacists, as well as doctors and nurses. And it really is the collaborative efforts of a specialized team like this which have resulted in the good outcomes that we now enjoy in the field of burn care. And while that's true, I think, for lots of specialties, I think it may be particularly true for burns, which does require such carefully coordinated treatment. Our burn center statistics look something like this. We're pushing about 400 acute admissions a year now, and about 6,000 outpatient visits. These are in-person visits to our clinic. Currently, telemedicine comprises about 10% of our outpatient visits. I'd point out that our mean burn size is only about 6% of the total body surface area, and I'll be showing some additional statistics on burn size and burn centers in a little bit of time in this talk. Our length of stay is a mean of about 6 days, and I would point out to you that our out-of-state patients comprise about a third, or a little more than a third, of the patients that we treat. So we take care of lots of people from Idaho and Montana and Wyoming. Children comprise 36% of our patients. We're the only inpatient facility at the University of Utah that routinely cares for children. And in recent years, as burns have become less frequent, our burn center, like many other burn centers, has evolved into kind of a comprehensive wound care treatment facility. So burns are certainly not the only things that we treat. And this is a perfect example. This is a picture of a young lady with a very severe Group A streptococcal infection. Group A strep is sometimes referred to as the flesh-eating bacteria. And here she is on presentation, as you can see, with a big area of full-thickness necrosis over her ankle and a lot of dusky discoloration extending quite a ways up her leg. We initially performed a very radical operative debridement. Here's a picture of her leg in the operating room with all of this dead tissue removed. And after that stabilized, we were able to cover this with good quality skin grafts, giving her what I consider to be a very acceptable appearance and a perfectly functional leg. So the treatment of soft tissue infections, big soft tissue traumas, blistering diseases of the skin, and other things are one of the big disease states that burn centers typically treat and that we treat here at Utah. Well, I'd like to start with an example of a patient, and this is a case that I've presented many times before, and if you've seen it before, I apologize, just bear with me. This is patient one, and we were called several years ago by an emergency room physician from a very remote small town. He had a 60-year-old man who had been burned while fighting a fire in his garage, and the patient had suffered burns to his face, scalp, and hands, which the physician estimated at about 15% of the total body surface area. He thought that the facial burns were extensive, and he was very concerned that the patient would require endotracheal intubation prior to transport. After talking with him a bit, I didn't think that that was the case, but we certainly agreed that he should be transported to Salt Lake City. This is kind of what the patient looked like on admission. Much of his facial burns actually turned out to simply be soot and were washed off without difficulty. I estimated his burns at about 3.5% of the total body surface area. They're all very superficial injuries, and we were able to treat him relatively easily. Let me point out as I go on with this presentation that it's not my intention to denigrate or cast aspersions on emergency room physicians. The physician who sent him to us was a very well-intentioned doctor trying to do the best he could, and he called us in a very appropriate manner. It's simply that evaluation of burns is not something many doctors are very good at, and that led to some discrepancies between his assessment and our assessment when the patient arrived. The patient's hospital course was relatively brief. It took us about 10 minutes to debride his wounds and cover him with a topical antibiotic ointment, but he had to spend about 48 hours in the hospital because he had to wait for his family to come down and get him. And like a lot of families, they had to get time off work and stop the mail and feed the dog and get gas in the car. And then they had to drive about 600 miles to Salt Lake City, learn to do his care, and then drive home. A colossal amount of expense and inconvenience for these people. In 2005, the hospital charged him $4,700 for 2 days of acute care in the burn unit. I charged him $166 for an admission history and physical and 1 day of daily care, but his air transport was almost $14,000. So his air transport costs about 3 times more than his total hospitalization. This was in 2005. A similar patient last year cost over $24,000 to fly to the University of Utah. Here's patient 2. A very similar kind of story. I was called again by an emergency room physician, not the same physician, from a remote small town, not the same town. He had a 60-year-old man who was burn priming a carburetor and had burns, as he said, all over his face. He was very concerned that the patient would need to be intubated and transported. And after some back and forth, he was able to take a photograph of the patient with a cell phone and send it to me over my cell phone. A glance at the patient told me that this was a very superficial injury. He did not require endotracheal intubation. He did not require air transport. And I was able to advise the physician about some topical care. And the patient was able to stay in his hometown. And he was very satisfied and happy with that. And his physician was as well, as you can imagine. And I think these 2 cases simply illustrate the potential of telemedicine to extend expertise in burn care or almost any other specialty to many remote areas. Well, you have to start somewhere with burn care, and if you want to talk about the history of burns, a good place to start is with World War II. World War II kind of inaugurated a new era in the treatment of burns because of the many burn patients that were generated as a result of enemy conflict during the Second World War. And even before the Americans entered World War II, on Pearl Harbor Day, burns had emerged as a remarkable problem in treatment as a result of the conflict in Europe and the Blitz in England. They were seeing far more burns in this war than they had ever seen in any previous war because of the very large number of gasoline-containing vehicles, incendiary devices, and high explosives that had been developed during this period of time. But on December 7th, 1941, as most of you know, Pearl Harbor was bombed. There were many, many burn injuries. There were 2,402 immediate deaths at Pearl Harbor, and that contrasts to about 2,700 deaths at the World Trade Center in 2001. Of the 1,282 wounded patients, over 60% of these casualties were burn injuries. So burns dominated as the major healthcare problem following Pearl Harbor in 1941. An equally important event for the burn care community was a fire that took place in Boston a little less than a year later in November of 1942. The Coconut Grove was a nightclub that was very heavily attended and packed with celebrants on this Saturday night. When a fire broke out in the basement, the patrons tried to escape through a revolving door, which quickly got jammed. They were trapped in the building. Many, many people died from smoke inhalation. There were over 490 deaths and over 400 people injured on that single evening. As you can imagine, hospitals in those days were not equipped at all to handle such a high number of casualties. But as luck would have it, both Boston City Hospital and the Massachusetts General Hospital had both received research awards to study burns as a consequence of World War II, so they were very well prepared, or at least relatively well prepared, to take care of this very large number of casualties. Many discoveries and developments came out of the Coconut Grove fire. This was really the first burn center organized in the United States, one of the first formal descriptions of fluid resuscitation, the first description of inhalation injury, one of the first descriptions of post-traumatic stress disorder, which would become known during World War II as combat fatigue, and many other developments which occurred. So burn care really got established in the United States, at least, with the beginning of World War II. Since that time, care has continued to improve due to a variety of discoveries and improvements. As you can see from this slide, at the beginning of World War II, a man in his 20s with a burn of about 40% of the body surface area would have a 50% chance of dying. This has gone up progressively with the development and perfection of fluid resuscitation techniques, topical antibiotics, early surgical excision, critical care, and finally the development of effective skin substitutes. So that now a man of the same age can probably have about a 50% chance of surviving a burn of 85 or 90% of the total body surface area. Survival has gotten much, much better in recent decades and continues to improve slowly today. Interestingly, as survival has gotten better, the incidence of burns in the United States has gone down very significantly. And that's due to product safety legislation and smoke detectors and a variety of workplace safety mandates so that people don't get burned at the same rate that they did in the past. Our goal, obviously, is to reduce these numbers to zero. But in 1971, there was an estimate of about 1.2 million burns in the United States, severe enough to require medical attention. That's down now to about 450,000. And while there were about 10 burns per 10,000 Americans in 1971, now there are about 4.2 burns per 10,000 Americans. And obviously there are more Americans, but even so, fewer people require hospitalization and far fewer people die than in the past. Another interesting statistic is that as the number of burns has declined, the frequency of big burns admitted to burn centers has changed very dramatically. This is data from a number of sources, including the American Burn Association. And I'll direct you over to 1971. In 1971, 26% of the patients admitted to U.S. burn centers, these aren't all hospitals, these are burn centers in the United States. 26% of patients admitted to those hospitals had burns under 10% of the body surface area, and 11% of patients had burns in excess of 50% of the body surface area. So a relatively small number of small burns and a relatively large number of big burns. But over time, you can see how this has changed. Now, in 2011, only 2.7% of the burns admitted to U.S. burn centers are over 50% body surface area, while 72% of the burns that we admit to our burn center are under 10% of the body surface area. And you would think that many of these patients would not require admission at all, but in fact, even a burn of 6 or 7% of the body surface area can be a very severe injury. It can certainly require very specialized care and rehabilitation, and with that care, we can obtain very, very good results. So we're not in the big burn business as much as we were in the past, and I am very fond of telling my staff, which they have heard me say over and over again, that we are in the small burns business. That's where we make our money, that's how we keep our beds full, and that's really the benefit that I think specialized burn care brings to a region like ours. We get people with small burns back to very, very high functioning status in a relatively short time with as little expense and as little discomfort as possible. And that's those are statistics, of course, we are continuing to try to improve. Overall survival in U.S. burn centers today is about 95%. So most patients do not die. The vast majority of our patients survive. So how has that affected our care and our priorities? Well, clearly, burn centers focused on survival as a major measure of their success for many, many years. But now, as most patients do survive, and many people with small injuries are at very little risk of dying, our focus is shifting more toward the quality of life for survivors and the benefits of rehabilitation. It's no longer enough simply for people to survive. Now we need to get them back to a very good quality life, back to work, and back to a normal lifestyle as much as possible. By the same token, as the healthcare landscape has been changing, we're focusing more and more on cost effectiveness, more and more on saving money rather than making money, and that makes it important, even more important, for us not to try to capitalize on our patients as much as possible, but to economize on their care as much as we can. And both of these factors have emphasized the need for us to develop partnerships with our local facilities. We share the costs for these capitated patients. We share the responsibility for their rehabilitation and to return to an active life. And we very often share the responsibility for their acute treatment as well, as our goal is to try to keep people in their hometowns as much as we can. It's not surprising that given the statistics that I've just shown you, not only have the number of burns in the United States gone down, but the number of burn centers in the United States has also gone down. From a high of about 185 in 1981 down to fewer than 140 now, and that number may actually be even a little bit lower today. As specialization has become more widespread, There are fewer centers which are larger taking care of burns, and that's probably true for many other specialties as well. In our region, that's a particularly big problem. This is a diagram that a fellow named Matt Klein, who's a burn doctor in Seattle, produced a couple of years ago, looking at access to specialized burn care throughout the United States. And you can see on the left side of your screen a map showing access to verified burn centers. These are burn centers that have been verified by the American College of Surgeons. On the right is a map showing access to any burn center or any hospital that calls itself a burn center. The dark areas indicate helicopter transport time that is 1 hour in duration. That's out and back. And the grayer, larger gray areas represent transport times of 2 hours. So as you can see, if you live in the western United States, and I put a red star on Salt Lake City, there are large areas in Idaho, Wyoming, Nevada, Montana, and even Utah that have little or no access to specialized burn care, or for whom transport to a burn center means a very, very long trip with very, very high expense and a tremendous amount of inconvenience. You can see that the western United States is just about unique in this regard, and we have problems with access and transport that really are shared by other areas in the United States. I'll show you some examples as we move ahead. So we looked at this about a decade ago to try to see where our patients were coming from and how their care was affected by the distances they had to travel. We looked at all of our burn patient air transports for a year from 2000 to 2001. We had 225 air transports during that period of time. As you can see from this map, each little black dot is a hospital that referred us a patient during this period of time, and each one of those little red stars is an air transport system. So it wasn't just the University of Utah flying to get these patients. There were transport systems in Idaho and Montana and Wyoming and Nevada that were bringing us patients as well. The mean distance that these patients had to travel was 245 air miles. That's one way just to get to the University of Utah. Obviously, they probably couldn't get air transport back home because insurance won't pay for that. And you can imagine that getting back down here to clinic or for any kind of follow-up care would also be very, very difficult. So we reviewed these 225 transports, and we looked at the accuracy of referring physicians in terms of evaluating burn extent and depth. And what we found is that the referring physician's average estimate of burn size was about 29% of the total body surface area, whereas our estimate of the same patients was about 19.7% of the total body surface area. That's a difference of about 9% of the total body surface area, which isn't a huge difference, but that ranged up to as high as 42% of the body surface area. A couple of the patients who were sent to us advertised as having very large burn injuries, in fact, turned out to have almost no burn injury at all, and their transport was completely unnecessary. 41 of these patients, or a fifth of these patients, had burns under 10% of the body surface area. They did not have airway compromise. They had no complicating factors. They probably didn't need to be transported at all, and certainly not by air. Of the 45 patients who were intubated prior to transport, 27 or 60% of those were extubated shortly after arrival in the burn center. In other words, they very well may not have needed to be intubated prior to transport. And intubation, as you can imagine, is a morbid and somewhat risky procedure. Most striking, to me at least, was that 21 patients, or about 10% of the patients that we transported during this time, like the patient I showed you before, had transport charges that exceeded their total cost for burn care. So most of the money that was spent on them was simply spent flying them down. And in 2000 or 2001, I think it would be easy to imagine why a lot of hospitals would probably regard these air transports as a very valuable thing. I'll go back and show you that map again. There are a lot of little red stars on this map, and some of those transport systems are very happy to have any air transport that they can get in order to make the money associated with that. But as we shift to a capitated system, the money that is used for transport is going to be part of the total reimbursement for care. And the more money we spend on helicopter rides, the less money we're going to have available for other things. So our psyche and our emphasis is shifting toward trying to save money as much as we can. None of these transports were done badly. None of these patients had bad outcomes. They were all more or less indicated, but I concluded at the time that I thought we could have done significantly better. So in response to that, we were able to obtain a grant from the Department of Commerce and created a demonstration project where we looked at establishing a limited telemedicine network for acute burn care. And with the grant money that we obtained, we were able to install telemedicine equipment in our facility at St. Alphonsus Hospital in Boise, St. Peter's Hospital in Helena, and St. Vincent Hospital in Billings, Montana. We constructed our own network, and we spent a lot of time talking to the doctors in those facilities about burn care and getting them comfortable with the idea of telecommunication as a way of evaluating acute burns. And I would have to emphasize the importance of this person-to-person contact as you're setting up any sort of telemedicine project. This really has to be done on a face-to-face, doctor-to-doctor basis, and it proved very effective for us. We looked at a 2-year period of time before the institution of telemedicine and a 2-year period of time after the institution. As you can see here, the number of patients that we evaluated increased almost threefold, from 28 patients to 70 patients. The burn size of those patients transported by air increased very significantly, and the patients with smaller burns were either transported by ground or didn't require any transport at all. In fact, 30 of the patients that we saw never had to come to Salt Lake City for anything. In the pre-telemedicine era, everybody got transported by air, whereas after the institution of telemedicine, only 44% of the patients were transported by air. And it took us a while to get the doctors accustomed to the idea that they could call us and show us a patient for consultation without expecting to send the patient down. I think sometimes they were a little bit reluctant to do that for fear that we thought they were trying to get a consult for free, but we tried to make the point that that was exactly why we were doing this. Pardon me. In addition, I assured the doctors early on that any patient that they wanted transported, because they were uncomfortable with the care, or there were psychosocial factors or family factors, if the physician wanted the patient transported, the patient was transported, regardless of what they may have looked like on telemedicine. And I can tell you that both patient and provider satisfaction was very high. Everybody was very pleased with the telemedicine service, and I'll show you an example of that a little later on. One of the things we did was to try to evaluate how effective video was in evaluating burn extent and depth. So we performed a very simple project. When the patient was admitted and they underwent their initial debridement and evaluation, one of the burn doctors would complete the standard London Browder chart, the burn diagram, evaluating the extent and the depth of the burns. At the same time, the evaluation was videotaped. And then we would show the videotape to the other burn surgeon who was not on call and did not see the patient on admission, and he would complete a burn diagram using only the videotape as a reference. And as you can see, while there were some minor differences in the way the drawings looked and the evaluation of the burns, we were almost exactly identical in terms of our evaluation of burn extent and depth. And that demonstrated to us the accuracy of video in providing these evaluations. When we compared the evaluation of the burn by the referring physician with the evaluation of the burn by the burn center physician, as you can see, there was a great deal of discrepancy between these two evaluations, and while there was correlation, the correlation was not very good at all. So there was a lot of over and underestimation of burn size made by the physicians who sent the patients to us. But when we compared the burn doctor who looked at the live patient with the burn doctor who looked at the video, as you can see, the correlation is almost exact. So we are able to get a very, very accurate assessment of burns using these video systems. So how can telemedicine help in the evaluation of acute burns? Well, as shown here, it can certainly allow for an accurate assessment of burn depth and an accurate assessment of burn extent. Those are the two factors that most obviously influence decisions about care, including the need for transport. In addition, sometimes burn patients require acute airway support. Telemedicine can be very accurate in assessing the need for that as well. That's a critical decision to be made early on and one that greatly affects the patient's safety and outcomes. The early institution of fluid resuscitation and escharotomies, I'll show you some in a minute, are also acute things that really need to be done before the patient is transported. These are things that many physicians don't have a great deal of experience with. It can certainly be used to justify air transports, and it also helps get air transports paid for. If the referring physician is able to say, we showed this patient to an expert at the University of Utah, and they agreed that the air transport had to be done, then the insurance company is much more likely to compensate for the transport without argument. And of course, if the transport is unnecessary, we can help provide documentation for that as well. In many situations, physicians simply need a little advice about how to provide care for the patient without really any consideration of transport. And in this situation, again, telemedicine has done a great deal of good in this regard. And that's one of the places where store and forward technology has proven to be particularly helpful. So I can't give a talk about burns without a few pictures of burn injuries. Bear with me, I'll just give you this as a little bit of a refresher. It's also a good reminder that telemedicine contacts can be used for teaching in almost every circumstance. This is a cartoon diagram of the skin, and it shows you the epidermis, which is the very thin, specialized layer of skin at the top of the slide, and the dermis, which is the much thicker, lighter colored layer of proteinaceous material, collagen and elastin, which is lower down. That's the layer of skin that gives you its strength and stability. And it's from that dermal layer through the skin appendages that healing of the wound will take place. So as long as those epidermal appendages are intact, the wound has the potential to heal on its own. Here's a typical picture of a scald injury in a little child. It's a very gruesome looking injury. There are lots of big watery blisters. The patient is going to be very anxious. The parents are going to be hysterical, and everybody's going to be very worried about this wound. But in fact, this already gives you very clear indication that this is a very superficial injury because of these very large water-filled blisters, which you don't get with more serious burns. And after the wound has been completely debrided and the blisters are removed, you can see that this wound is bright red in color, it is very moist, it blanches very easily with direct pressure, and it's a very painful wound because the nerve endings of the skin are still preserved. So while this is a gruesome looking wound, and certainly will incite panic in many family members, it's not a terribly serious injury. Topical care is probably all that's needed, topical care and pain relief. And this would be a patient that we could either see the next day or potentially reevaluate by telemedicine in a few days after some healing had taken place. This is another example of a very superficial burn, a scald burn in a little child. You can see the bright red skin. It's very moist, it's very painful, and it blanches easily with direct pressure. Topical care, maybe some fluid support, certainly pain medicine would be all that would be needed to treat a minor injury like this. These are all deeper injuries. You can see that the skin has either a waxy white color or a dark red color, but in either case, the surface of the skin is dry. The skin certainly sloughs, particularly with a little bit of direct pressure, as you can see on that man's face in the upper right, but there isn't any big watery filled blister like there is in more superficial injuries. These wounds are often not as painful as more superficial burns, so people tend to underestimate them, when in fact these are much more serious burns than the one I showed you before, ones which are very likely to require surgical treatment, and ones which we would probably insist on transporting so that they can get the specialized care that they need. This is a similar deep partial thickness burn after a few days of healing. You can see that some of the brownish tissue has fallen off. The underlying tissue is pink, and if you look very closely, especially around the wrist, you can see a lot of little pink polka dots. Those are skin buds. Those are areas where new epidermis is coming up through the underlying tissue, and those will gradually cover the hand with new skin and help the wound heal over. If we can get to a level like this or an appearance like this, within about 10 days to 14 days, we know the wound has the potential to heal on its own, and we can certainly follow a wound like this with store and forward technology or video technology from a remote site before we make the decision to transport for necessary surgery. And everything else, of course, is a full thickness burn or a third degree burn. These typically present with a dry surface. The wound can be almost any color, as the upper picture tells you. This is a little boy who was playing with matches and gasoline and caught his leg on fire. And you can see that some of the wound is red, some of it's brown, some of it's white, but it's all full thickness.